It's Lindsay Smith-Rogers, producer and co-host of Public Health on Call. Thank you for joining us for this season of the podcast. We'll be taking a break the week of May 25th, returning for season 14 on Monday, June 1st. As always, please keep sending your ideas and questions to publichealthquestion@jhu.edu, and thanks for listening.
Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
It's Lindsay Smith-Rogers. Today, a vision for fundamental reform of humanitarian health efforts across the globe. Johns Hopkins professor Dr. Paul Spiegel is the chair of the Lancet Commission on Health, Conflict, and Forced Displacement, which has released a new report that you can find linked in today's show notes. He joins Dr. Josh Sharfstein to talk about the growing need for humanitarian health operations and the multiple gaps in the current efforts, which were written for a much different time. He lays out the Commission's vision for change from local communities all the way to the United Nations. Let's listen.
Dr. Paul Spiegel, thank you so much for joining me today to talk about this Lancet Commission report on health, conflict, and forced displacement. The subtitle here is Health in a World of Crises and Impunity. And I'd like to start by asking you about the current picture of humanitarian health today in the world.
Thank you for having me, Josh. It's quite dire, and I'll give you some statistics. Between 2021 and 2024, conflict-related deaths have nearly doubled. There are 123 million people displaced presently, which is the largest number ever recorded. And the financial situation is so difficult at present. There are 239 people around the world who require humanitarian assistance in 2026, but only 87 million, or just 36%, have actually been prioritized to receive it because of the lack of financing. And I can go on. I'll just say one other statistic. $23 billion is the cost of meeting these life-threatening needs for the humanitarian people who need humanitarian assistance, and that's about 1% of the global military spending. So it is feasible, it's just not prioritized.
There are enormous humanitarian health needs, and there are not enough resources being put to address them. The report also talks about other challenges with the humanitarian response in 2026. Can you talk about those?
Certainly. There have been major issues for decades now in terms of the humanitarian response. So it's not as if this crisis happened just yesterday. There have been reform after reform that have mostly failed, and that's because the system itself was created for a different time, primarily after post-World War II. There have been a lot of both political interests, institutional interests that have just made change and transformation almost impossible.
So can you make that a little bit more tangible? What doesn't work about a humanitarian response, say, when there is a large group of people in need?
Sure. We can talk about Sudan right now, for example. It's one of the largest crises in the world. And it's relatively consistent. So I'll talk first about international humanitarian law, and then governance, and then financing. So in international humanitarian law in Sudan, in Gaza, in Ukraine, in Eritrea, in Ethiopia, international humanitarian law is consistently being violated with impunity. And for example, this year, there are documented more attacks on healthcare workers than ever, and it is consistently going up. So attacks on healthcare workers, on hospitals are occurring and even increasing, but there's little to no accountability. No one is really being held responsible. That's one example. International refugee law, as we've seen now in the past, when someone is fleeing persecution, they have the right to cross a border and then be accepted by that host country. That's not happening now. More and more people are being pushed back or not even allowed to cross into a border. So these are just some examples. The governance it's far too international focused. It's far too United Nations and international NGO focused. There's not enough true access to affected populations and having authorities and local NGOs actually run the show. And that's been consistent for a while. And a lot of it has to do not just with opportunities and access, but actually power and politics.
What are the consequences when humanitarian health efforts fail?
People die, and they don't just die from conflict affected. They don't just die from bombs and bullets, but in fact, most people die from an exacerbation of existing diseases, whether they be communicable diseases, outbreaks, or non-communicable diseases where there's just the lack of health system to provide them care.
So you went into writing this report recognizing there is an awful lot at stake.
Absolutely.
Now, the report is, I believe, 70 plus pages. It's a long report, but it has 4 major recommendations for change, and it has to do with this issue of governance. Can we start there?
Certainly. So what we try to do is to make define the typologies of crisis a little bit more, because it's clearly not a one-size-fits-all situations. So within the crisis typologies, we differentiate between new acute crises, which are rare, but when Ukraine happened, when Syria happened a long time ago, these were new crises, and it is much more difficult to be able to respond as effectively, and because you don't necessarily know who all the local actors are, and you've got different authorities with different legitimacy. We then look at the most common crises, which are acute on protracted and protracted crises. And the reason we differentiate that is because in those situations, and the largest 10 of those, for example, constitute the significant majority of displaced populations globally. And those, we know who are the authorities and their legitimacy. We also know the local NGOs. And we are really trying to push the UN and the international NGOs to justify, do you really need to respond? If you need to respond, why? What are you going to do? For how long? And what is your sustainability plan for the local NGOs to really make sure that the affected populations are really put at the center of the response?
So if I understand, a crisis starts anew, there's an important role for international organizations to jump in and help people who are affected. But over time, as local organizations emerge or are identified as being capable, the goal actually should be to give them the resources and the responsibility to provide for the response.
Yes, but I will nuance to say, even in these longer term, either acute on protracted or protracted, it really depends. It'll be a spectrum. So you've got some, an example is a very strong and capable government like Turkey working with the Syrian refugees versus another government such as South Sudan, which has more challenges. And so we're not saying that it's even in those other situations that it always needs to be the local or the authorities. It really depends on the situation, and it'll be like a spectrum or a spectrum of response accordingly. There'll always be a role for international organizations and the UN, but that role will vary according to context.
Got it. Now, let me circle back to your point on the lack of accountability. What did your commission recommend to address that?
So firstly, with lack of accountability, it is not just focusing on international law. It is focusing really across the board, from lack of accountability from donors, lack of accountability international agencies, but also towards ensuring that there is an accountability towards affected populations. Most of the accountability in the system is really towards donors. How much money did you get? What did you do with it? And how do you report? We want to flip that on its head and really talk about an accountability across the board, number one. Number two, though, is when we're focusing on accountability in international humanitarian law and refugee law, we recognize that there is a big problem. There is impunity, and there is a lack of accountability, but it's very difficult to change because a lot of this is political in nature. And so given the current environment with the UN Security Council, it's unlikely immediately that that's going to change. So we try to look at it layered. We try to look at it at a domestic level where governments can train their militaries, they can have civil society. We do look at it at the international level. And then because we want to ultimately focus on health, we want to use healthcare, attacks on healthcare workers, continuity of care, lives lost, mortality, to try to have measures of accountability that are tangible.
In other words, there should be multiple points of accountability, not just waiting for the UN Security Council, that citizens, organizations should be rejecting the idea of attacks on healthcare and other violations of international law.
Yes.
Let me ask you about the third recommendation here, which was to fix the money. How do you fix the money?
We have to fix the money by ensuring that money is ultimately used for or provided for the needs of a population and not for political considerations. This would be hard to do. And again, in the current geopolitical situation where we find more and more towards transactional funding for transactional elements, it's going to be a challenge. However, we do have four different areas that we want to focus on. Number one, probably the most important one, is to move towards some sort of global pooled fund where money goes into such a pooled fund so that you're not providing funding, governments are not providing funding bilaterally, but rather a pooled fund that then dispenses that money according to need and politics is removed. We recognize the political environment right now may be more complicated for that, but it's ultimately a way that we think is really important. There are current pooled funds. They're mostly UN run. We believe that may not be the most efficient way to be able to run such a global fund, and probably moving towards public-private partnerships would be stronger. Secondly, this is, I think, one that many people can agree on, is that cash-based assistance, so providing cash to populations, providing them agency, providing them the opportunity to decide which goods, how they want to spend their money. It also helps the local economy. So that's another area that I think many people agree upon. And then the two other areas that we think are quite important and feasible. One is that in many of these protracted situations, particularly long-term refugee situations, it's not necessary. In fact, it has negative consequences for the international community to be providing parallel health systems to these populations. In many situations, the social protection systems, there is even health insurance, government health insurance in many countries. And we have had experience where refugees and other displaced populations can actually move into a government-run system. Money goes into that government system when it's working, and that can actually both improve healthcare for host populations. And then finally, the last one is innovative financing. This is something that will be complex because of risks in predicting these conflicts, but there are a lot of different innovative financing mechanisms, from anticipatory action to different types of disaster bonds, that may be able to be better used in this situation.
So less money that is spent at the last minute for a parallel effort to the current health system, more advanced planning, money that's put into funds that can be separated from politics, and money that goes to actually support the underlying economy and health system.
Absolutely.
All right. The last recommendation here was to prioritize health in thinking about humanitarian health. What did you mean by that?
So what we wanted to look at health across the board, and we didn't mention this, but typically a Lancet Commission would start just at health, and they would focus on communicable diseases, non-communicable diseases. And we do that in this area. But we recognized early on the humanitarian system is not fit for purpose. So if we don't change the power structure, if we don't change the governance and the financing, we're not going to improve health. And so we did take a different structure of how we wanted to develop this commission. And the last part is health. We want to, number one, look at continuity of care and make sure that is the default position. When you have such displacement, continuity of care can be difficult, but it is a right. And when health systems are disrupted, we need to be able to better figure out how people can continue with their care, particularly in, of course, communicable diseases, but here we're talking chronic diseases, mental health. And there are ways to do this, and one way is to develop an essential package of health services at different levels. It's not going to be the same in Ukraine as it's going to be in another much poorer country, but there should be a minimum level of services. Secondly, as we mentioned, we want to integrate as soon as possible displaced populations into national health systems and social protection systems. The next one is that we've seen good examples in Turkey where Syrian refugees were actually able to start providing care to other refugees. But we really want the Commission proposes that refugee and displaced health professionals be given licensed pathways to be able to practice. There are so many nurses, doctors, dentists that sadly, because there's so much displacement globally, and they're not able to practice. And this would actually help both the host country and the affected populations. And the last two are a strong focus on mental health. It's been I wouldn't say ignored, but not enough focus has been on mental health. And this is from the Rwandan genocide, from Vietnam. There's just been so much. There have been mental health issues that have primarily been ignored, and only now are we starting to address them. And then finally, we want to look at the protection of healthcare workers and facilities to be treated as a system-wide operational priority and not just a legal obligation. And as I mentioned, it could be a very good and strong measure for accountability.
Among your recommendations, do you suggest changing the structure of the United Nations to bring them about?
Yes, and in many ways. Number one is there are too many UN agencies that are involved in these humanitarian emergencies. And so we are suggesting a pared down one UN operational agency. It would be from all the various different agencies, while the separate UN agencies would keep their normative framework. We're also suggesting that the current coordination system, which is primarily called the cluster system or the refugee coordination model, should be changed, particularly in acute emergencies. It's too consensus-based. It's not effective. And so we're suggesting to move much more towards what's called an incident management system, which has a bit more command and control.
The report is comprehensive, and you're really trying to take a new look at a system that has helped millions of people over the years, but has left these significant gaps. One of the major changes, at least to my reading, that you're proposing has to do with the historic principles of independence and neutrality. When you think about humanitarian health, my image is the Red Cross coming in, having nothing to do with any government on either side, dropping in, setting up services that people can line up for. As you're shifting to more local organizations, as you're thinking about different kinds of accountability, it seems like you're loosening your grip on those two principles. How do you think about that, Dr. Spiegel?
Yeah, no, thank you for pointing that out, because it is quite important. These principles are made at a different time, the humanitarian principles, and we are by no means rejecting those principles, but we want to perhaps change the emphasis according to context. So there are classically four principles: humanity, impartiality, neutrality, and independence. And even when they were written a long time ago, in the 1890s, neutrality and independence were subsidiary to humanity and impartiality. So those humanity and impartiality we propose still remain sacrosanct. We then actually suggest three new principles, particularly focusing on the health-related humanitarian health, which are do no harm, which, as we know, is also a classic medical principle; solidarity, and by this we mean solidarity with affected populations. That will also help with this movement towards localization; and accountability, because there's been such a lack of accountability across the board. But then when we move towards neutrality and independence, which is probably a more controversial aspect, what we're suggesting is that it depends on an organization's mandate and it depends on the context. So a group like ICRC, the International Committee for the Red Cross, they will always be neutral and independent because they're seeing prisoners on both sides. They are going to be trying to work on both sides. Many international NGOs, similarly, when you want to be working on both sides. But we're now seeing, particularly as we move towards local NGOs, many local and either national, but particularly subnational local NGOs, they're working in one area. They need to be impartial and they need to, of course, put humanity above all else, but they don't necessarily need to be neutral. That doesn't mean that they're supporting the warring factions, but they don't have the objective of necessarily on working on both sides. They don't even have that opportunity. And it has been used in the past to this lack of neutrality, particularly for local organizations, has been used to say they're not following humanitarian principles, they can't get money, or it's been used to muzzle organizations as well. And so we're saying that neutrality and independence are operational tools. They're a means to an end, and it may depend on the organization's mandate and the context.
So there may be a situation, for example, where a local organization has opposed a particular action by one side in the conflict because they felt it was very important for the population that they are part of, but that shouldn't disqualify them from serving that population if they're in the best position to do so.
Absolutely. Absolutely. And I know there will be some pushback on this because these four principles have been around for so long. We don't talk necessarily about governments all the time. We talk about authorities because in many countries now, sadly, there isn't one government that's in charge of the whole country. So we need to look at authorities, and then similarly, we need to look at their perceived legitimacy and those local NGOs, the legitimacy of the community. And many of these authorities and the local NGOs, they may not be neutral, but they are providing significant humanitarian services to these affected populations.
It's a big agenda. What is going to be necessary to accomplish it?
Well, I believe this is a once-in-a-generation opportunity because we've seen in the past, so many attempts to reform the system, and it hasn't happened because it's not going to happen voluntarily. Because of this massive funding crunch, which is very problematic, it also is a time for change and for transformation. But one of the concerns I have is that we are so polarized at present. And I do believe ultimately people do want to help populations who are vulnerable, but it's going to mean that people are going to have to coordinate much better. They're going to have to put aside a lot of their grievances and their prejudices. And I'm talking mostly governments and donors to be able to come together to seize this moment.
Dr. Paul Spiegel, it's a very, very interesting and important report. Thank you so much for taking the time to talk to us about it.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.